Now let's talk about the management of the prolonged latent phase. So we talked about what the prolonged latent phase is. Now let's talk about how to manage it. So the first thing you need to do to manage a prolonged latent phase is therapeutic rest. So why do we need to have therapeutic rest? Remember, the mom has been dealing with the latent phase for over 20 hours in a primigravid and over 14 hours in a multigravid. And these are strong uterine contractions, and they're very tiring. So what you need to do is give IV analgesics such as morphine to relieve any discomfort for the patient and relax them and allow for labor to progress while the patient rests. You don't want to have them be in pain and discomfort for too long a period of time, because after the latent phase and the active phase, they need to start pushing. Uterotonic drugs can also be given. So oxytocin is a natural hormone in the body that allows for uterine contractions. But if that's not converting the cervix into the active phase and it's still stuck in the latent phase, you need to give exogenous IV oxytocin to activate uterine tone and cause more contractions and accelerate the progression of labor. And this is a very effective treatment to go into the active phase. So one time you avoid oxytocin if there's some reason not to give it. So fetal malpresentation, if the fetus is in breech position or some other abnormal position, you don't want to give oxytocin because you'll push the baby even further into the abnormal position and cause problems. Or a hysterotomy scar. If there's a previous C-section or uterine surgery, you have to be careful giving oxytocin because that could cause a uterine rupture, and that could be very, very bad for the mom and the baby. So be careful when you're giving oxytocin for these situations. Also, if the amniotic fluid membranes have not ruptured yet, you can give amniotomy. Amniotomy means you rupture the membranes, and this can trigger further contractions. And oxytocin can be given with amniotomy to help this. And this will help you accelerate the latent phase into the active phase. So how about C-section? When are you going to do a C-section? A C-section is avoided unless there's an arrest of labor with 3 criteria met. So don't ever do a C-section unless there's arrest of labor with at least 6 centimeters dilation, so it has to be an active phase, ruptured membranes, and adequate contractions. If all these 3 are met and labor is arrested at these 6 centimeters dilation, you can do a C-section. But until then, a C-section should not be considered. So let's do a practice question now, applying the knowledge we've learned so far. What is the next best step in management? A. Reassurance. B. Oxytocin infusion. C. Cesarean section. D. Uterine relaxant. Or E. Turn patient onto her side. So we need to figure out what's going on here and how to treat it, okay? So a 22-year-old G1P0, meaning gravida 1, first pregnancy, P meaning 0 parturition, so no births, so the first primigravid woman, is admitted to the labor and delivery unit with strong, regular uterine contractions. Okay, so she has strong, regular uterine contractions, and after 22 hours, her cervix is 4 centimeters dilated and 40% effaced, with minimal change in the last 2 hours, and the fetus is in a cephalic position. So she's stuck in this 4 centimeters, 40% effacement phase. And it's been more than 20 hours, so what is she considered? Right, prolonged latent phase. Okay, so this is her first child, and she's getting worried that something is happening to her baby. The attending physician asks you, the resident, what to do. What should you do next? Are you going to reassure this woman after 22 hours of pain and contractions that haven't been going anywhere? Absolutely not. You don't want to reassure. How about oxytocin infusion? Oxytocin infusion would be helpful. Remember, we talked about how oxytocin is a great option if you want to convert the latent phase to the active phase. And what are the 2 contraindications? If the fetus is in an abnormal position, cephalic means the face first, that's a normal position. And if there's a hysterotomy scar, but this is her first pregnancy and she has no history of any uterine surgeries or procedures. So oxytocin infusion is a great answer choice to keep. Alright? C-section. Remember, we don't give C-section unless we have a reason to. Remember, greater than 6 centimeters and having membranes ruptured, regular contractions. And without that combination, you cannot do this. How about a uterine relaxant? Is that going to be helpful? No, because if you give a uterine relaxant, you're going to make this even more delayed because you need contractions to dilate and efface the cervix. So it's not going to be uterine relaxant either. And turn the patient onto her side. What is that really going to do? Is that going to cause her to contract more and have more cervical change? Definitely not. So the answer is definitely the oxytocin infusion, letter B.